resume recording. And to add more latecomers, sorry about all these interruptions. And my mouse is lazy. So, as I said, once again, who is that? Oh, everybody is in. No imaging is required if patient management will not be altered. So we can go through a few common scenarios. Trauma is a big one. Cough, belly pain, breast pain. Cough you all don't deal with, really. Chronic back pain, altered bowel habit, jaundice, headache, seizures. And you notice that it's going quite far and wide because you all are in surgical training and you all will branch off into various subspecialty areas. So I did not tailor this for a so-called general surgeon, just surgeons in general. And my radiology residents are here with me as well. So let's look at belly pain. Could be right upper quadrant pain, could be right upper quadrant tenderness. And as you all should know, pain is what the patient complains of, and tenderness is what you elicit on examination. Could be lower quadrant, could be generalized, it could be in the flank, it could be non-specific. It could be due to hepatobiliary issues, urinary tract, ovarian, uterine, bowel, other causes. Plain films, ultrasound, fluoroscopy, and CT would tend to be more utilized in this situation. MR would play a smaller role. So I'll just use a few clinical examples to illustrate. So who is going to tell me what these films are showing? Who is EJ Charles? I'm asking you a question, EJ Charles, or however I pronounce your name. My apologies if I got it wrong. What are you seeing on this X-ray?
Good evening, Doc.
Good evening.
So the X-ray on my left, I'm seeing multiple air fluid levels. So it's abdominal X-ray of the index patient showing.
And it's the same patient, I think, on the right-hand side. So, sorry, on the left. So what are you seeing on the other image?
So I'm seeing loops of small bowel dilation.
What's the difference between the two of them?
One will be erect and one is supine.
So which one you think gives you a better illustration of the pathology?
The erect X-ray.
You guessed the wrong one. Actually, I'll quote Val Cottrell. I don't think you guys know Val Cottrell. He was a senior surgeon at KPH. And he said it nicely that the supine X-ray demonstrates to greater advantage the anatomy of the bowel. And it's true, because you get a better idea of what is going on. Yeah, you see the fluid levels on the erect, but some of the details you pick up on the supine are a lot more useful. And if you had one image to pick, go for the supine, but nobody's going to do that. They always want both of them. So what's the commonest cause, EJ, of small bowel obstruction in surgical patients?
So causes of small bowel include
commonest cause.
Is it strictures?
What?
I know malignancy is one of them.
Anybody want to help? I'm sure I saw Anushka. Let me call one of the surgeons who's name. Deji. I hope I pronounced your name correctly. What's the commonest cause of
adhesions?
Thank you. Adhesions. If you get a patient coming in, usually you would have the history of prior surgery, but sometimes you don't get a history. And it's really, really common. So let me let in a few stragglers. Carl Brown, one straggler. Right. So here we have some more bowel obstruction. And here we actually have some large bowel. And the large bowel looks different from the small bowel because now you're getting haustra. which are interrupted, as opposed to the valvular conjunctives that you see in the small bowel. And you're all supposed to have learned that very well as medical students. I'm sure I saw, let's see who else is here. I need to ask somebody else a question. All right, let me ask my surgeon. Dwayne Campbell, what do you think is wrong with this patient?
A big crowd and a lot of people coming through. I'd say we typically have carriers for animals here. It's kind of anything.
Somebody needs to mute their mic.
I've seen cats.
Dwayne?
Hi, afternoon, Doc. I'm actually driving at the moment, so I can't get a chance to look at the image.
What we have in a tutorial, well, I guess you can hear some of the talk, but you're going to miss the images, and that's what radiology is all about. But anyway, that's your excuse, and you're sticking to it. All right, let me trouble somebody else. Garvin Seaman. What do you think is going on here?
So there's a dilated loop of large bowel, looks like a volvulus.
Yeah, it is a sigmoid volvulus. Well done. Straight to the point. So this is another case of, actually, we'd call this a localized ileus or so-called sentinel loop. My mouse has gotten rat poison. It's terrible. And here is the CT of the patient. So you see what you see on the plain film, you have 2 dimensions and you have very, very limited soft tissue contrast. And now you have here cross-sectional imaging utilizing X-rays again, but because of how the machine is designed, you have different detectors. You can see much better soft tissue differentiation, which is also facilitated by the ingestion of oral contrast, as well as the administration of IV contrast. And what's going on here, the patient has a sentinel loop because of an underlying necrotizing pancreatitis. So you see the pancreas, you see places of the pancreas that are enhancing normally, but there's a big portion of it's grossly edematous and it's not enhancing. So this is classic. And there's a little bit of fluid here and a little bit of fluid there, a little bit of free fluid. So this is quite classic and it's a nice case. So this is a big one. Jabari, you want to take a stab at this? Let me send somebody in there. Or just point out to your colleagues what it is you're seeing. So there's the arrow there and arrow here. What's this arrow pointing to?
There's oval calcification which overlies the right ileum. So that's on the film, and it corresponds to a calcific density on the CT.
But tell me about the plain film. What do you think it is? Look at the plain film, because you can speak about it right here from the location and stuff, as well as this associated finding. So what would you think it is?
Likely an appendicolith.
What is this here? The black arrow. What's that pointing to?
It's not really.
You're not seeing it? All right, that's the story. I'll go with that. There's a fluid level in the obstructed appendix. So this is an unusual thing to see with a plain film. So it is actually diagnostic of acute appendicitis, but that's not what we normally see. It's unusual to get all that detail. So we have 2 other choices. We have sonography, which shows a thick-walled and would be non-compressible appendix. So this is very, very specific for acute appendicitis and should be utilized more often in children. And this is what has supplanted everything else, CT. And we don't like to use CT as the first line in kids because of the radiation dose. Radiation dose from CT went up with the multi-detector. And you know how it is used, gay abandon and multiple body parts are imaged repeatedly, and the doses of radiation became concerning. And we'll talk more about that later. But so this would be in keeping with this. And this here, you can see the different patients. If you had that size of appendiculis, you would have seen the bright structure here with some shadowing. But all the patients had appendicitis. This is probably a diverticular abscess. This article was actually about pitfalls in CT diagnosis. And one of the things with CT, you actually can't get to do the graded compression that you get when you do your ultrasound. So you can make mistakes with the CT. It's not foolproof. And I just drew this in for good measure. So this is an MRI coronal view in a female patient who could well have been having belly pain due to degenerating fibroids. It's a large fibroid uterus, or bladder here. Okay, so MR is not usually the front line. CT and ultrasound are there, and out in A&E, a lot of plain films are done as well. So let me let in a few more. So in this elderly patient with dysphagia, so barium swallow, you can see this dilated, ragged looking esophagus, and you're seeing what we call a rat tail with shouldering. So this is classic for carcinoma of the esophagus. So certainly now you have made this diagnosis on barium. You want to stage the patient, you want to look at local involvement as well as potential for distal involvement. You'd move on then to CT and then probably other modalities depending on what you find at CT. Patient with altered bowel habit. A beautiful double contrast enema demonstrating, I think this marker is in the wrong place and the image is laterally inverted, because this looks like the liver here, which is supposed to be on the right side, and the flexure is higher up on the wrong side of the patient. So here we go. So there is an annular constricting upper core lesion consistent with carcinoma of the bowel. This is called colonic cancer. Chronic back pain, it's a big issue. Lot of lost hours at work, lots of money, lots of frustrated patients. Could be this disease, facet syndrome, sacral joint, focal bony lesion. And they say in the vast majority of patients with isolated back pain, there's no precise diagnosis. But there's a lot of imaging that takes place. So I have a few here. These patients would have presented with back pain. So this is a plain film taken in the lumbar region. And here you can see a normal disc, a normal vertebral body, normal vertebral body, normal intervertebral disc space, same thing here. But here you're noticing the disc space is narrowed and there's destruction of the inferior and adjacent superior end plates. And this would be consistent with an infective discitis. Here we have pars fracture in this patient, and they're going to get on to have a spondylolisthesis eventually. And here you can see the difference in the detail on an MR. Sagittal T1, sagittal T2, and the detail is exquisite. You don't get this soft tissue differentiation on anything else except MR. And what we're seeing here is a nice not for the patient, wedge compression deformity of this lower thoracic vertebra. So you see a comparison here of the various details that we can get. And as I said, for spinal issues, especially in trauma, doing a plain film first is not a bad thing. But if you have not answered your question, you get on to more detailed investigation. iPhone. I don't know who is this person named iPhone, but I am not going to admit them. I'm actually going to remove them because I cannot identify them. So you all watch me remove this person. So if they complain to anybody, you tell them that they need to identify themselves. I'm not letting them into the meeting. I see they can't, they won't be able to rejoin because I told Miss Bennett that, and you're all supposed to know that by now. When you're trying to join a Zoom meeting, people should be able to identify who you are. That is how we prevent Zoom bombing. Right, so I'm going in the right direction. So here we have a patient who would have presented with seizures, and this patient would have had headache. And in cases like this, both for seizures and headache, doing a CT first is quite acceptable. So the patient on the right has fresh blood in the subarachnoid space, the cisterns, consistent with a ruptured aneurysm, more likely on the right side. Also another right-sided lesion. So here we have the lateral ventricle. So this is about middle of the head. And we have some bright hyperdense areas here, more bright hyperdense, and heading into some tubular looking structures. So this is a post-contrast run. So this would be consistent with an arteriovenous malformation. So now we get on to more detailed studies. So this is CT angiogram, which you could do for patients who presented with subarachnoid hemorrhage to locate where the aneurysm is. And here you have the early phases of the study. Actually, here you can see a synaptic area in the right middle cerebral. These are later phases, and you now start to see the veins filling up the sagittal, the transverse straight sinus. So you can do CT angiography, CT venography. Here we have a catheter study. Don't know how many, you should have observed stuff like that by now. We do the puncture in the groin and send up the catheter with the guide wire. And such studies are tend to be reserved nowadays for when you're trying to do some invasive work. So this patient has this humongous supraorbital vein, which is not right. Here's the ophthalmic artery, the internal carotid. So there's a carotico cavernous fistula. And they have put some coils. You can actually, if it's well protected, there's a little ghost here of the coils that they put to block off the fistula, so you don't get the vein being that big and dilated. And here's your nice ophthalmic artery. So that's another interesting case. Also, I think trauma. Poor fellow, not looking too happy. We have a patient with head injury. Plain films are not very useful. If you have a simple fracture, it's not a big deal. If you have a fracture, you worry whether it's a compound fracture or whether you have a bleed associated with the fracture. Then you need to go to CT. So you need that to exclude intracranial hemorrhage, contusions, herniation syndromes, basic skull fracture. So all of the blood that you're looking for, you could actually find it on MR, but MR is not readily available. It's very slow, and it's not conducive to the trauma patient from the point of view of, if you have any life support equipment, they can't go in there, and it takes too long, and the patients probably can't cooperate very well. So CT is frontline in trauma for all different body parts. So here's a case that I did the CT. So this is the scout film, which doubles as a lateral. So have a look. Yes?
Regarding the plain films for your skull x-rays, is there any indication where they are useful?
See it here, I'm telling you now.
Oh, okay.
All right. So here we are. Can everybody see this little lucent area? And there's some brighter spots here. Who was just talking to me? Speak to me now. Can you see the brighter spots and the darker spots? Circle here?
Yes, I can.
All right. So what has happened in this patient is there is a depressed fracture. Here are the fracture lines, and these are some of the fragments which are now evident on the CT because it's gone underneath the table, the outer table. And here are the associated intracranial bleeding with it. So the point is, the skull X-ray, it's basically a waste of time if you think that somebody had a severe enough head injury that they need some form of imaging. You need to get the neurosurgeons on board and get them a CT scan. Because doing the skull X-ray is just adding radiation, wasting time going to and from X-ray, and then, as I say, if there's something serious happened to them, they're gonna need a CT. So just a little reminder of your dural anatomy. The facial trauma. So same thing, you can demonstrate some of the stuff that you find, some of the injuries on plain film, but the detail just is not going to be there. So here we have a person who was basically punched in the face, and the films are diagnostic to a point. So this is the left orbit. Here at the right orbit, you can see the little teardrop, which is in keeping with a blowout fracture, and you see a fluid level in the maxillary sinus below it. But we can't tell you what is in this little soft tissue density here. During the CT now, you can actually see that the muscles have dropped into it, the bone window and the soft tissue window, and you see prolapse of the muscles. You see the muscle itself. So you can see stuff with plain X-rays. And I mean, if you're in a situation where that's all you have, well, use it. But as I said, you know, if there's a severe enough injury that you actually need to image, and most times you probably don't need to image if it's some kind of minor injury. Somebody slapped somebody else in the face. They don't need a X-ray, they don't need a CT. But a direct blow to the eye, high-speed injury, a brick drop on the head, they fell head first over a balcony. Don't waste time doing any plain films. So you stabilize the patient, you send them for their various CTs. Somebody is messaging me. Is working. Anyone else not hearing her? Everybody hearing me? Or somebody is complaining that they weren't hearing?
No, we're hearing.
All right. All right. Spinal trauma. So I showed you some X-rays of the person with the part fracture. So you can use X-rays for spinal trauma because you can see the compression fractures. You can see, you know, posterior elements or whatnot. You can see the loss of alignment. But usually if the injury is severe enough, as I said, sometimes you don't need to have done the plain films in the first place. And you might need to move on to CT. And you all will learn, you did your X-rays and the patient has a serious, particularly a high-speed injury, and we can't see the C7P1. Sometimes we'll go on to the CT, especially if the patient having CT for something else. But sometimes we get a shopping list kind of event or approach, and it's not generally very helpful because usually the patient can cooperate sometimes without these whole lot of X-rays. Nothing really wrong with them. Sometimes the CT is not going to be the thing. If you think there's soft tissue ligamentous injury, you can see the loss of alignment on CT and even on the plain X-ray, but you can't exclude hematoma or a traumatic disc at MR. So the mechanism of injury and the symptomatology of the patient become very important. As I said before, MRI is not trauma friendly, it's slow, and it's not compatible with life support equipment. Extremities, plain films mainstay. You drop out of the mango tree, you broke your hand, you broke your ankle, blah, blah. You have point tenderness, you have deformity, fall on outstretched arm, things like that. X-rays. front line, front and center. So sometimes you need particular views. And please, guys, just remember that we have a job to do, as do you. And your job is not to supplant us or to tell us that we don't know what we're doing, however subtly or not subtly. Because sometimes you see clinicians, well, it's funny to say clinician because the point is we all do clinical work, asking for specialized radiographic views. And sometimes they are completely out of, they ask for the wrong view. It's not your job to know stuff like that. The most important thing you need to do for us is to tell us the history of the patient. And query PUD is not a history. Fall from a height is not particularly helpful. We need to know how high did they fall from? Was it a scaffolding? Did they fall off a balcony 3 floors up onto their head? Did they fall from a standing position? Did they fall out of a chair? Were they asleep? Were they unconscious when they fell, so they fell hard? Did they try to protect themselves? So we need a history from you, and we need to know what is the question you're trying to answer. So when you write query PUD, it is supposed to be at the end of something, you know, like epigastric pain for 3 months, query PUD, not just query PUD. We need a history. We need a history. I had a very unpleasant experience with one of my colleagues who actually saw fit to basically report me to her head of section because my resident had started asking around for a history on a patient on emergency that they would not provide. And when I responded, I actually included the hospital's lawyer in the correspondence, because the fact is, if we are looking at images and we need a history and you're not providing it, we're going to ask whoever will help us. A lot of times we ask the patient. Sometimes we ask some other referring physician because, you know, sometimes patients go to multiple services. So we need to know, and you need to tell us, and we're wasting time when we don't hear these things. So, abdomen, big area. So in films, you can see pelvic fractures and stuff like that, but usually you go for CT, you're looking for internal organ injury. You can also use ultrasound depending on the nature of injury, or the question to be answered, or if it's a pediatric case. MRI is not frontline. And of course, I think, no, I didn't forget. Here it is. I put a reminder to myself. I forgot to take out the reminder. And here you see this patient who had an abdominal injury, and they have a liver laceration with a hematoma in the liver, that's parenchymal, and a subcapsular hematoma. There's some free fluid here. On this slice, we're not seeing any other organ damage. Breast pain is a common thing. Up to 70% of women suffer from benign nostalgia. May or may not be unilateral. Not an indication for mammography, but if the patient is of age, if they're age appropriate, you send them for their mammogram. And it's not usually recommended in women over 40. You have a strong family history, you start earlier. A patient has a bloody nipple discharge. You shouldn't ignore it, even when the mammogram looks normal. They wonder where this came from. I mean, the general surgeons will be looking after patients who complain for breast pain, and some of you all, everybody has women in their family, and doctor know everything. And so you need to have some basic information. And I basically lifted this out of the medical student tutorial. Screening. That's another big area for radiology, as I will demonstrate. And so these are the characteristics of what would be the ideal screening test. Inexpensive, easy to perform, reproducible, highly sensitive. And, you know, if something is very sensitive, it's not very, tend to be less specific, and you would need to do diagnostic studies. So like when you do the mammogram and you find something, you have to go on and do a biopsy. Sometimes you do additional views, but the biopsy is what is going to tell you what's really there. And do you need to do a mastectomy or whatever? And of course, the disease for which you screen has to have available effective treatment because it is the worst form of terrorism to be finding stuff in people. You go on a hunt for it, and then all you have to tell them is that you can't treat them. That's not cricket. Individuals must be at risk for the disease. So that's why we don't screen women under the age of 40 because their risk is pretty low at under the age of 40. They tend not to, the risk of getting breast cancer jumps after the age of 40. They're asymptomatic. That's how you define screening, because if you're symptomatic, you're now trying to diagnose a problem, not screen. And they must be willing and able to undergo diagnostics and treatment if the screen is positive. So even like now, this is not a screen, but you consider somebody that's subarachnoid hemorrhage. I remember getting a patient years ago, sent from the ward for a 4/6 vessel angiogram. So I'm now about to poke needles and tubes and toxic chemicals into this person's body. So I'm going through the consent process with them. And I speak to them about what would happen if I found an aneurysm and that they need to clip it after having done a craniotomy. At which point the patient wanted to know is whose head I think they was going to cut open. So basically I would say, well, I think we're done here. And I sent the patient back to the ward with a note. Because if the patient wasn't willing to undergo aneurysmal clipping, there was no point doing the angiogram. So that is a part of the screening. There's no point screening with the patient, not going any further with it. And the life expectancy must be long enough to see a benefit. And 10 years is what the suggestion is. So these are some common malignancies: breast, cervix, prostate, colon, lung. And you see the test: mammography, CT colonoscopy, low dose chest CT. So for 3 of the 5 big ones, radiology is involved. And actually there's a little update that I saw when I was doing this, but we'll talk about that in a second. So we talk modern is part of the backdrop. And I just threw this in, we're talking about mammography, trying to keep you awake. So this is what the old time film screen unit used to look like. And I've kept the same design for the 2D, and I've kept the same design for the 3D. So they look basically the same. You just notice more pedals here. So that's pause for refreshment. And here we have some little update here. This is contrast enhanced mammography. So we actually don't have the capability with our new unit. We need to buy some add-ons. But what it does involve is injecting contrast into the patient. Same contrast used for CT and so on. And you use a filter to burn out the soft tissue and to highlight the cancer. So we have a speculated lesion here. And this is a lot more recent than breast MR, and actually it might end up taking over from breast MR if some of the pundits are to be followed. Actually, I think it makes a lot of sense. So this is a little update. So I got a sidebar with the mammo. So there is now a quick scan, 15-minute contrast-free MRI. It detected more clinically significant prostate tumors than the usual screening in a study of 408 British men. So the quick MRI scan, they found 14 Gleason 3 to 4 or higher, and PSA only discovered 7. However, that was a small study, but things keep changing. And this, I just saw this. This was published in March 2021. So that's something to watch out for. So it would mean then that of those big screening programs for malignancies, radiology would now be involved in 4 out of 5. And we don't screen for lung cancer here with the low dose screening. It's something that's relatively new and it hasn't really taken off, but it can actually reduce loss of life. And breast cancer screening with mammography has been under study. It's been studied from in the 1960s. And there is no question that it reduces loss of life. And this is highlighted by the fact that breast cancer in women is still a lot more common than lung cancer, but lung cancer in America has now taken over as the leading cause of cancer death in American women, even though breast cancer is more common, because the lung cancer is still killing them, but the breast cancer rate of killing people has gone down significantly because of mammographic screening. So we spoke about screening. So something that can happen is unintended screening. So you're looking for something and you find something else. So this is a CTPA that was done. And the patient didn't have any clots, but they had a pleural effusion, which probably explained their shortness of breath. So renal cell cancer, I thought, was a nice little one to bring forward to highlight this unintended screening, because a lot of renal cell carcinoma is detected on other studies. You're not looking for it. You find it. You're doing some abdominal imaging. You're actually doing, sometimes you're doing lumbar MR. You see the leukocyst in the kidneys, and you tell them to go for further imaging, and then they find the cancer. And what has happened is there's a whole host of these cysts, and you all will learn, if you have not done so yet, about the Bosniak classification. And they actually had to reclassify how you manage these findings, because they said a lot of the cancers they were finding were indolent, and here they said insolent. And the surgical rate for resection of kidneys, partial nephrectomy, removal of kidney in entirety, had gone sky high, and the mortality rate had not changed. But the morbidity had also increased now, and the cost of doing all of these surgeries, and they weren't saving lives. So they actually had to do a reclassification of the Bosniak system, and that was done in 2019. So that is illustrating that things progress, they change. It's not static. You don't find out something and then it's never going to change. It might change by the time you finish speaking. So we have detected, we have diagnosed, and now we're looking at staging. CT is one of the workhorses. You look for local spread and lymph nodes. MRI is particularly useful in staging of pelvic tumor and also looking at bone mets. Nuclear medicine is a workhorse for looking for bone mets, just normal scintigraphy bone scan that you'll know about. The whole body bone scans are very common for looking for bone mets. And plain films are not very good at excluding bone mets. PET scan is also a form of nuclear medicine. And here we lead into fusion imaging, PET CT, PET MR. So this is the supposedly normal PET scan. It's actually SPECT because they have done a section. And here you have it, AP, and this is sagittal. So here you see the marriage of the nuclear medicine and the CT, and what it does, it improves. So that's the CT, that's the PET, and here's the joint effort. So it improves your anatomic precision, and you're better able to localize where the lesions are found. So that's how fusion imaging has come in, and that's one of the more recent things that has developed in radiology. That was like in 2008. And unfortunately, PET MR is so expensive, it hasn't really taken off. And it doesn't look likely to, not in the near future anyway, because most places cannot afford it. So here we have a patient who was sent for staging. There's this large abdominal tumor. And it's the same patient, you can see these lung nodules. I didn't find any bone lesions, but so this is part of how we do staging using CT. So you want to read X-rays. There you go. So do you need us? And a lot of you think that you don't, or you think that you're to tell us what to do. There's no point telling us what to do. You must tell us what you need, and we can figure out what you need to do, what needs to be done. So anyway, the first evidence of surgery was from 6500 BC. And this is a specimen that lives in the Smithsonian. They used to drill or cut holes through the skull to expose the brain, and it was thought to cure mental illness, etc. That's a thing. It used to happen from 6500 BC. And I'm sure that, and they never, and you see radiology started 1895, which was millennia later. Several specialists do their own procedures, like cardiologists, orthopods, some neurosurgeons as well. Several hospitals don't have any radiology posts. I know I can speak to in Jamaica, and they might have visiting radiologists or none at all. So basically, surgery was being performed from basically prehistoric times, and radiology by definition is modern compared with surgery. A radiologist is a qualified medical doctor. We are facilitated by our technical staff, the radiographers, who are well trained in doing their thing. They operate equipment, they troubleshoot, and we have to work together. So radiologists are medical doctors that specialize in diagnosing and treating injuries and diseases using medical imaging and procedures, which I've spoken about before. So this came from the Royal Australian and New Zealand College of Radiologists. It was a document put out by them on the role and value of the clinical radiologist. It was in 2014. The radiologists represent one of medicine's least acknowledged but most important medical specialties in terms of the value they are able to add to patient care and health outcomes. They were often behind the scenes of a pivotal role in patient care, and we use our general clinical skills and our specialist radiological knowledge to provide care for the patient, whether it's for diagnostic tests or treatment, because we can do treatment via invasive stuff. And they still, and radiologists in some areas covers also radiation oncologists. Sometimes they are put under the radiology umbrella. So we use our expertise to determine which imaging techniques, if any, are most appropriate, how best to use the selected imaging technique, like the protocol, the studies, interpretation of the acquired imaging, the writing of the report, which my residents can attest to. I terrorize them about. It needs to be clear and have the relevant information in it. Communication of findings to the referrer in a time-appropriate manner, and we do try. And I, from the days I was a resident until I still see it now, you send the report out and serial persons from the same team come asking for the report that you sent out before. And all hell breaks loose and they start quarreling, why isn't the report out, and the report was sent out long ago. So communication is key. And we also need to suggest follow-up of the patient as appropriate, or if you think that there's follow-up that needs to be done and we never suggested it, we discuss and we organize it. Right. So this is a little joke here, but actually Marie Curie, who had shown you, who had discovered radioactivity, she actually died from leukemia in her 60s, which was because of radiation exposure. So what do you mean by modern? You think any of these people are modern, or you think they're old time and they're outmoded? Motor car came from 1886, and the smartphone, where was the smartphone? 1992, You know who Stephanie Germanotta is? That's Lady Gaga, and Robin Fenty, and Peter Hernandez, Bruno Mars. Here's the X-ray there. So modern is actually what you define it as. I've been talking about history, but it's not over, and it's important to understand what happened historically so you can understand what's happening now. So these are some principles that we learned early in the day when I was in training 500 years ago, and it's still taught, and this is a little more recent. So justification is a principle that states that you need to justify the performer. You know, any study that is performed needs to be justified before you perform it. If there's no justification, it doesn't need to be done. It is going to cost the patient something, whether the trauma of doing it, whether the radiation exposure, the exposure to IV contrast, the exposure to coming into this bizarre department that has all kinds of strange equipment that they've never seen before, the financial trauma, all of those things need to be justified. And then we go by also the ALARA principle. So once you have decided that you're going to expose a patient to radiation, as low as reasonably achievable. So sometimes the images are not the prettiest, not what we would have wanted, but if we can use it diagnostically, we won't repeat it so we don't radiate the patient again. And then there's this concept of image gently. It came out of the American Association of Pediatrics, I think, and they started to speak about this thing when they were started to get worried about, you know, how much radiation kids were exposed to from multi-detector CT, which can be quite sweet. And as I say, there is no question CT helps to save kids' lives, but radiation matters. So more is not better sometimes. When CT is right to do, you look at the size of the child and you manipulate the factors, and you do one scan. Sometimes they're asking for multiple scans, I don't need anymore. You only scan the indicated area. They cut down on the radiation dose to the kid. As radiologists, we're also taught of the pitfalls of imaging. And we can tell you sometimes whether or not all the while, but if we suggest that there's an artifact or there's a potential artifact, an artifact is an artificial fact. It calls the finding into question. And if you are not even aware that artifacts exist, you could get yourself some serious trouble. So you can get artifacts from overlapping structures, clothes, opacities on the skin, nipples, skin tags, whatnot, densities in the stool, beam hardening, misregistration, and so on. So this is axial MR, patient moving all over the place, so there's a lot of motion artifacts. So this is basically useless. This is MR again, and this is what we call a zipper artifact. And it's because the Faraday cage has been disrupted. So in other words, the radiographer needs to close the door of the scanning area. Axial CT, is this an infarct? Is this a tumor? Or is it an artifact? Artifacts can sometimes look just like this, and you need to know there could also be an artifact here. So those are some of the things that we learn about and that you should not want to bother yourself with, because that's why we're here. This is not something that happened 500 years ago. This patient lost their hair after radiation exposure in a medical department. A 53-year-old woman with a subarachnoid hemorrhage. It was temporary, it lasted 51 days. And it was seen on day 37 after the first perfusion study. So notice she had had several, and it scans in the same location. That's why you got the ring. So it said radiation-induced temporary hair loss. So she had both MDCT and DSA. And this was in 2004. And you know, the literature will show that even the staff exposure, personal exposure, it tends to be higher when non-radiologists are at the helm because they're not trained in radiation safety like a radiologist. Some common causes of mistakes when you're trying to interpret a scan: inadequate or misleading history and patient details, failure to review previous studies. There's a little place on the card, previous studies, and sometimes I think y'all leave it blank because you think it will slow down the process. It will facilitate the process. And the point of the matter is, whether you say it or not, we are going to look for it. So if you tell us it makes our life easier. If you have the CD, tell us you have the CD and you send, and if you don't want it to get lost, you send somebody with it and will copy it and send it back to you. Observer error, fatigue, and distraction. The whole team of English surgeons come barging in the room with arms akimbo, and everybody starts to panic or gets equally belligerent. We need to treat each other with a little bit or a lot of respect. It's all about the patient, it is not about us. So, as I discussed before, we have plain films, blah, 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 blah. We went through all of these. And something new here, portable MR. They actually have MRI now that they can drive onto the ward. I think it was just recently approved by the Food and Drug Administration. I saw it not last year, the year before last, at the big radiology meeting in Chicago. And the field strength is low. So the field around which you can't approach and worry about credit cards and magnetic things flying is really, really reduced. And you can basically plug it into the wall. I mean, it's a major, major advance. The manufacturers claim that on planet Earth, it's roughly 10% of populations that have access to MR. I'm not sure if this is an underestimate, but the point is, there's a lot and lot of persons who would never have access to an MR because it's just too expensive. And I mean, this will make the modality a lot more available. And it's not as versatile, of course, as the bigger magnets, but it can do certain things. So this is my take on best practice. Modern radiology should involve radiologists. The most suitable modality in any given situation is not necessarily the one that is most recently developed. Studies should be appropriate given the clinical situation, including the patient characteristics. I cannot tell you how many times I forget patients who were supposed to have barium enemas who were violently incontinent of stool. They wanted them to have a barium meal and they were in respiratory distress. Doesn't work. There are lots of different guidelines available for best appropriateness criteria from the Royal College of Radiologists, the American College of Radiology, and there are many more. And guidelines continue to evolve. And I quote here one of my professors, Professor Ralph Richard. He was an internal medicine specialist. He said there's no such thing as third world medicine and first world medicine. There's good medicine and there's bad medicine. I actually forgot to put the citation here. There's an article that was put out about 2 years ago. I think it was a study done at Stanford that actually discovered or strongly suggested, and I don't hear anybody having sued them, and it was at Stanford, that medical error was the third leading cause of death in the United States of America. So that again, medical error was found to be the third leading cause of death. Cardiovascular disease, then malignancy, then medical error. So trauma come underneath that. So car crash and gunman could not keep pace with the errors of the medical profession. And I think that that is a very sobering statistic. What we do is all about patient management. We do the best we can with what we have. And the fact that we don't have robotic surgery available does not mean we cannot do anything. Most people will never need any robotic surgery in their life, this life or the life to come. Somebody joining us late, I'll let them in. Oh, but that's another one. Mac operating systems. What is that? No, I can't add them. Remove. Sorry. Okay. I don't know who that is. I can't admit anybody who is unidentifiable. That would be just silly because there's no point having a waiting room and a list of class people and you don't have a name. So, good medicine and bad medicine. And there's no shortage of bad medicine in situations that resources are plentiful. So we do not answer to this angry doctor. We answer to this pleasant doctor. No, no, you're all supposed to know this gentleman, Professor Howard Spencer, who is our medical registrar, and he's head of medical council, and they will tell you how many times they are well occupied by the bad behavior of us medical professionals. So remember, we are in the team and we're looking after patients, and teamwork makes the dream work. So any questions? I have hold several mouthfuls and I am tired now and I would like to hear something from you guys. Is there anybody who is still awake?
We're awake, Dr. Soros.
Oh, you are. Everything was fine? No questions?
It was a very good presentation, and guess I'll speak for the group and say thank you very much.
Well, thank you for thanking me because it took a lot out of me. But I do enjoy fiddling around and putting stuff together sometimes. So I'm glad you all enjoyed it. Anything that anybody wants to ask? No? Everybody tired, me tired too. So just to remind you before we close, we are here to assist you. We are not here to be beat up and we're not here to beat you up back. Good? We are meant to work together to facilitate
Hi,
the patient.
afternoon,
Yes,
Dr.
hi, who's that? Yes, ma'am, who
Sorry,
is this?
hi, I'm Christian. Sashai Christian.
Okay.
Hi, afternoon, Dr. Soros. I have a question. I've been asked
Yes.
before, in terms of the CT, when we do them for abdominal pathologies, what are some of the signs that would suggest bowel compromise, or inflammation essentially of the bowel? I've been asked that before. And what I have seen or read, we may see fat stranding, we may see edema, but something about enhancement of the bowel wall, I wasn't too clear
Yeah,
on that.
sometimes it can hyper enhance.
Mhm.
And if it's bad enough, it won't enhance at all.
Oh, okay, okay. So is it that, so lack of enhancement could indicate
So, all
ischemia?
right, so
Uh-huh.
yes, of course, because
Right.
it's supposed to enhance. I mean, you're going to see the best enhancement when the wall is sick, because there's
Right.
more of it, and if it's inflamed and it has more blood supply.
Mm-hmm.
But you know, I would prefer for those things to be discussed when there's an actual case in front of you. You can't learn stuff like this in a vacuum.
Okay. Not
All
sure.
right, and
Oh.
you know that's why you're all in the hospital, because as Barry Hanchard of blessed memory would remind us, you all are apprentices. So you're not at home learning the stuff in a vacuum. You have to be in the hospital with the patient. So anytime you have a patient that has stuff and you say your patient have mesenteric ischemia, whatever, and you can't elicit the findings, you don't know what you're looking at, call up your colleague, say Javon or whoever it is in an X-ray. Beg you show me what you were talking about. And that's how you will remember it. All right, thanks for the question. Anybody else have any questions? And I cannot overemphasize the importance of a history. What I have found, a lot of any residents pass through radiology. And I'm always very gratified when they finally leave and they say they are so embarrassed when they are now on the receiving end of the little nonsensical history that they actually used to write histories like that and send to us. And I said, well, if you don't learn anything else, you learn something very important. Because it's a referral. It's not an instruction. It's not a, it's supposedly a request, kind of, but it's really a referral. You tell us you have a problem with a patient and you would like for us to do so and so. And after we see what you put there, whatever, we decide, yeah, this sounds like we can help you, or it sounds like we can't. And if we call you for further information, do not jump up in arms. And I mean, I'm still shocked. I mean, some of my residents, one who just recently graduated, said, you know, some resident in surgery actually came up and said, you know, we are there to do what they say. I don't know who the person was. And I remind my residents, that's why they have consultants. And one night, there was actually some nice teamwork by the radiologist, myself, and one of your consultants, because the resident was given trouble. And I called the consultant. And so when we provided a united front, there was nowhere for the resident to turn because they thought that we wouldn't be talking to each other. I don't know why they would think so. Because this is how we're supposed to work. The patient is the focus. The patient is meant to be the focus. It's hard work. It can be very distressing. It can be very rewarding, but it takes a lot out of you. And people's nerves are on edge. You're ragged because you don't get enough sleep, whatever. But try to be civil. The patient will benefit, and so will you. And as I say, you catch more fly with honey than vinegar. Anything else? We're good. I can sign off now.
Thank you.
You're very welcome. And I hope you're doing well.
I am. Thank you.
Good, good. So everybody's okay. So I'll call the proceedings to a close then. Have a good evening, everybody, and thanks for showing up and thanks for your attention. And I hope it was of benefit. And we will meet again, I'm sure, because we can't hide from you. We are here. All the best and stay safe.